I'm going to ask Dr. Brita Roy to come up and give this next presentation.
Wonderful. Thank you for having me. My name is Brita Roy, and I actually used to be at Alabama, actually with Nicole, and trained at the University of Alabama at Birmingham. So I actually have experience working in that same county hospital, caring for local inmates as well. And since then, I have moved up to the Yale School of Medicine, where I am now the Director of Population Health, but actually spend most of my time as a researcher focusing on positive social and psychosocial factors at both the individual and the community level that actually may start to hopefully mitigate the disparities we see in cardiovascular and other chronic disease risk and outcomes. And so with that, I thought today I might talk about the time periods both before, during, and after incarceration, and talk about both the individual psychologic needs during those 3 time points. I'm going to use self-determination theory to describe those needs, and then also provide a picture of the community context before, during, and after incarceration, which impacts people's abilities to be able to meet those very basic needs. I'll also be introducing the model of social quality to describe the community context, and I'll be talking about some theory and models. I'll try not to make it too boring, but I do think it does help to provide a framework for these really big concepts. In the end, we'll describe how the individual and community contexts do contribute to health outcomes and what we can maybe do about them. So Nicole has already described the great disparities we do see in health outcomes, and individuals who have been incarcerated do have higher prevalence of a variety of chronic conditions. And the reasons for those are multiple. We've already talked about health behaviors. People have different agencies of meeting either healthy or unhealthy behaviors during these different time periods. Also, exposures to different types of infectious diseases. We've already heard about tuberculosis and HIV. There's also limited access to and fragmented healthcare, again, as we spoke about already. And what I hope to talk about today is more of those psychological and social risk factors that contribute to poor health outcomes. So in a formative paper, Ryan and Deci described what they call self-determination theory, and this describes 3 very basic psychologic needs of an individual. The first is autonomy, which is the ability to control one's life. The second is competence, and that is feeling like you have the ability to effectively manage your environment. The third is relatedness, or the need for close and supportive relationships. So the ability of an individual to achieve these 3 basic needs is very dependent upon the environment in which that person lives. And that environment includes their family interactions, organizational and community surroundings, as well as societal policies. So to understand what the community context looks like and the different aspects of the community that impact the individual, I'm going to introduce the model of social quality. So just to orient you, the bottom of the model refers to individual level supports, and then the top of the model describes societal level supports. On your right is informal relationship supports, and then to the left is formal or institutional supports. I'm going to start with your bottom right corner, self-regulation. Self-regulation is similar to self-efficacy. Self-actualization is another term that's already been used today. It is basically the ability of an individual to act as an active agent and decision maker. It is the ability of a person to really alter their own internal states and processes, such as the thoughts, feelings, desires, and actions in anticipation of meeting future goals. So that is self-regulation. And that you can see is pretty directly linked to this concept of autonomy or having control over your own life. Moving counterclockwise, the next quadrant is social embeddedness. And so this refers to social and peer support, having trust among your friends and neighbors, others in your community, and having shared values and norms with that community as well. So this is also very related to the basic need for relatedness and close supportive relationships with others. On the top left, living conditions is the degree to which people have material and immaterial resources over time relative to their standard of living in society. And so this is very related to one's socioeconomic position in society. And finally, so societal embeddedness is access to basic services like healthcare or other types of social services. And so these two on the left side of the diagram relate to competence, or again, the ability of a person to be effective in dealing with their environment. So finally, we can kind of see how the community context actually impacts an individual's ability to meet their three basic psychologic needs. So now let's talk about how these are influenced by incarceration. So prior to incarceration, I'm going to start again with sort of the self-regulation piece. Most individuals who are incarcerated come from disadvantaged neighborhoods. And we know that there are higher levels of exposure to trauma and adverse childhood events within those neighborhoods. Adverse childhood events include things like living in a home with a parent who has been imprisoned, a parent who has died, divorced parents. It can also include living with someone who's mentally ill or currently abusing substances. It may also include witnessing violence among adults within the home or being a victim or witnessing violence either in the home or in the neighborhood. So these factors, these exposure to trauma and adverse events actually negatively impact one's ability to self-regulate. And this is, again, usually before incarceration. Again, moving counterclockwise, because those communities often have this history and cycle of trauma, the social fabric is often torn. And so the communities have lower levels of connectedness and support and trust among neighbors. There's also higher levels of perceived discrimination, which again, reduces one's feeling of feeling included in society. Moving to the top left part of the diagram, with lower levels of education and income or lower socioeconomic position, many members of these communities don't have very good living conditions compared to the rest of society. And they also have limited access to healthcare and social services, as we have already discussed today. During incarceration, self-regulation is highly impacted due to trauma, anxiety, and fear. And then also, oftentimes, a learned helplessness or really inability to adapt due to the lack of autonomy many folks have while imprisoned. In addition, we have a lack of connection with family members or other potentially previously supportive relationships. There's a lack of trust amongst members that are currently imprisoned. And then there's a social isolation, especially among those who are in, for example, solitary confinement for long periods of time. Finally, because one is in prison, there's often a lack of meaningful employment or activity, which also impacts the living conditions quadrant. And finally, post-incarceration, moving back often to the communities that they came from pre-incarceration, they now have a cumulatively higher exposure to trauma over the life course, poorer coping skills likely than when they went in, low self-esteem, and they're often much older, now potentially with chronic health conditions, as we've already talked about. When they return to those communities, many of those social networks they had previously been engaged in may have actually shifted. So prior potentially positive relationships may no longer exist, or their networks may have changed over time while they were away. They also face greater stigma and discrimination just due to the fact of having been incarcerated. And because of their history of incarceration, they also have much more difficulty in the ability to obtain meaningful employment. Finally, as we've already talked about, although they may have had health care while incarcerated, when they leave the system, there is fragmentation. It is often challenging to get back into health care, and also just other basic aspects of being a good citizen and being part of the community. Things like the ability to vote is often either taken away from people, or they don't know how to get their rights back. So with all of that, as I promised, this is not completely a lesson in psychology, but we also want to relate it back to health. And so I actually wanted to quickly show you a brief video from Unnatural Causes, which was a short series on PBS, now probably about 8 years old, but it does a great job of describing how the community environment, how living in a disadvantaged neighborhood can actually get under the skin and impact one's health. And I just think they do a great job of describing it. Oops. Let me see if I can. There we go.
We had vast public investments in building the suburbs of America. Federally supported loans, FHA loans, went to people who were moving to the suburbs, and for many years, up until the 60s, those loans were available on a racially restricted basis. African Americans and other people of color didn't have access to them.
Until 1962, out of $120 billion in government-backed home loans, less than 2% went to non-white households. In Northern California, between the war and 1960, of 350,000 federally guaranteed new home loans, less than 100 went to black families. In cities like Richmond, African Americans were left behind in increasingly neglected neighborhoods. In the 1980s, poor Latino and Southeast Asian immigrants began joining them in these same neighborhoods.
Once the community starts to go downhill, nobody wants to actually invest in the community, so the banks don't want to come in and the shops don't want to come in. Then you don't have a commercial base, you don't have the community taxes that can then feed back into the schools. Now you don't have good schools, so families don't want to move into the community if they don't have to because you don't have good schools, and you get a sort of vicious cycle of everybody who can will leave the community.
This isn't something that happens overnight, and it isn't the fault of the people who live there. The people who live in low-income, disinvested communities did not do this to themselves.
20 years before his heart attack, Kwai tried to move his family out of Richmond, but 11 months later, they had to move back.
I can't find my job up there, and she can't find her job up there. And moved back, my older son, hang around with the wrong group and then use some kind of drug I just don't know what to do. I try to help him. I try to straighten him out. Spend a lot of money, owe people a lot of money. That's what in my mind all the time. So it's worry, just worry. When I'm going to pay up all of this, and how I'm going to do it.
เดือนเนี่ยก็น้องอัลกุ้มน้องคาดเคลื่อนอันนี้ก็ยัด disparity จะแห้งนั้นเริ่มมาเจอแล้ว
If you think about when you're worried, you're always a little bit more activated. There's a little bit more vigilance. You're sort of checking things out a little bit more carefully. And if you can imagine that happening day after day, all day, every day, it's exhausting. And it wears on the body system.
When stress is chronic, when we're endlessly worried about our bills, our job, our children's safety, the body pumps out cortisol and adrenaline. But too much of these stress hormones over time can increase arterial plaque, raise blood pressure, and weaken our immune system, increasing our risk for almost every chronic disease, including heart disease, the leading killer in America.
We've done studies that have shown that living in disadvantaged neighborhoods is related to an increased risk. It's about 50 to 80% increase in risk of developing heart disease. And this has been replicated in other studies.
So to sum up from that clip, basically what we're talking about is living in disadvantaged neighborhood environments, being incarcerated, leads to this lack of being able to meet those three basic psychological needs: autonomy, competence, and relatedness. That is very stressful and leads to this sense of chronic, ongoing stress over time, which studies now show actually leads to this higher levels of low-grade inflammation, as well as unhealthy behaviors. And so those two things over time actually contribute to poor health outcomes and greater risk for things like cardiovascular disease. So data from the National Longitudinal Survey of Youth actually demonstrates this, that those with a history of incarceration really do have much higher rates of chronic diseases that have direct or strong links to chronic stress, like anxiety and depression, hypertension, and chronic obstructive pulmonary disease. So when we think about solutions and how we might be able to mitigate some of these disparities, it's really important to think about these root causes. So on that left side of the model for social equality diagram, we talked a lot about the environments, the supportive societal environments that that can potentially mitigate disparities, and that would be providing access to healthcare and other necessary social services like housing, reinstating basic rights like voting, but also paying very close attention to education and meaningful opportunities for employment to re-engage folks when they come back to the community. In addition, on the right side, on the individual side of that model, we talked a lot about the development of positive psychosocial traits. So these include things like social and emotional regulation, resilience, and adaptation skills, as well as this concept of self-efficacy, to be able to manage your environment and have control over your life. But I think we also have a really great opportunity to think about the social connections and strengthening healthy, positive, reciprocal relationships among these individuals, and think more about how we might be able to enhance involvement in the community. So not only is that beneficial for the person, but that's also transformative for the community themselves. And so with that, actually, in New Haven, outside of the transitions clinic, we've also begun to sort of explore some of these ideas of, can we actually have an effect on some of these root causes? And so we have been working with community members from some of our most disadvantaged neighborhoods to actually measure things like social cohesion, or the connectedness, trust, and bonds among community members, and collective efficacy, or the ability of a group to actually affect change on their own behalf. And we see that these two factors of social cohesion and collective efficacy are inversely related to exposure to violence in these neighborhoods. And so our community is starting to think about, well, they have control over social cohesion, and they might be able to develop ways to actually glue some of that social fabric back together and strengthen those bonds amongst their neighbors. And maybe that will have an influence on violence and distrust among neighbors, which in the long run we expect might break actually the cycle of trauma, may have a positive impact for the individuals living there, not only socially and psychologically, but also positive downstream effects for their health. And so that is all I had for you today. Happy to take some questions.
Thank you very much, Brita. We have time for questions, and so please step up to the microphone if you have any.
Good morning. Thank you for the talk. I'm a psychologist by training, and I'm thinking of a man I was working with from Wilmington who lived in not the best neighborhood and had a history of PTSD, was doing well with it, recently assaulted, flared back up PTSD. So I said to him, we can do what we've done in the past, you responded well, probably take us about 10 meetings. Or we can try to figure out a way creatively to get you out of your neighborhood. Mm-hmm. And we were fortunate enough that we were able to do that. Took us a couple of meetings, engagement of some resources. PTSD went away miraculously. I can't move everybody out of the bad neighborhoods, nor would that be, a goal that I would want to pursue anyway. How does a health system, in light of all this overwhelming research on social determinants, not healthcare delivery, play a positive role in that? And you started to get to it at the end. I wonder if maybe you could speak to a little bit more of those efforts that you're working on.
Sure, absolutely, and that's a fabulous story. And I think healthcare is very used to thinking about all the things inside the walls of their clinics and hospitals. However, healthcare systems do have a very big presence in their communities, and they have a potentially large role in supporting those communities. And so I think actually healthcare systems can, and I would posit should, collaborate with others within their own communities to be able to start working to improve those neighborhoods, from the ground up. They can work with housing, they can work with social services, they can work with the mayors. There are many folks to be able to engage, but healthcare does have, they have resources and they also have leadership, and so they can often be the ones to engage these various sectors and actually trying to change the communities around. And I should have also mentioned working with the community members themselves as well.
Yes, sir.
Good morning. You kind of touched on what I was going to ask you. Have you seen any instances where people have used a model of enlisting prisoners to assist with some of these healthcare issues?
Yes, absolutely. And so that's also something that we are doing in New Haven. When Emily gets up to speak about Transitions Clinic, she will mention that she actually hires previously incarcerated individuals to work in the health system as community health workers, and they also have been working with us to connect us to other community members in these neighborhoods as well.
What about inside the prison?
While inside the prison? That is a great question. I currently do not work with anyone currently in the correctional system, only once they have been released. But I think that's a fabulous idea. And I think as long as we're working closely with the Department of Corrections, and again, that trust is built and we're really collaborating with them, I think that would be a fantastic next step. Thank you for that idea.
So I really appreciate the comments from the psychologist that was speaking earlier. In terms of my understanding of exposures to stress, we know PTSD is a very commonly recognized entity, but then also complex trauma, complex PTSD, disorders of extreme stress not otherwise specified, these things where people live in a community or are exposed to violence in a continual basis in which they do not feel safe. And I understand prison perhaps doesn't help to contribute to that. And so when they are being reintegrated into society, there needs to be a period of time, per my understanding, where they do feel safe. And so some of that is being able to be moved out of that community, being able to live in an area where that safety is established before therapy can actually be effective and be continued. Now, my question is in relation to mental health therapy, mental health resources and services, and I would love to draw on the experience of other people with the Transitions Clinic. But a lot of what we target and what we have available for mental health resources is really psychiatry, which is more medication-driven, which is oftentimes, I think, targeted more at the extreme manifestations of these responses to stress, often miscategorized and misdiagnosed as bipolar, as ADHD, when really it's the manifestations of feeling unsafe in this sort of community. And therapy being demonstrated in the evidence, in quite a bit of evidence there, to being the key and the mainstay. However, if these patients are barely having access to Medicaid, and even if they were enrolled into Medicaid, yes, they have access to psychiatry resources, but has there been bridge programs and access to therapy and counseling? And as a disclaimer, my wife is a counselor, and so I have a little bit of a bias towards that. But being able to have that sort of ongoing long-term relationship with essentially narrative exposure therapy, other sort of therapies that have been demonstrated to be effective, that is in between, you could say, psychiatry or being overseen by psychiatry, but I think from a funding perspective often doesn't have that piece in place by the state. Have there been any sorts of efforts or any sort of thoughts that engage exactly the issues that you're describing from social determinants of health?
Mm-hmm. So another great point is that psychology therapy is crucial for these individuals before and during and after incarceration as well. And funding for therapy is very much a challenge. Different states have different programs and different areas have different access to therapists. Actually, in New Haven, it's interesting, people that have no insurance and have Medicaid actually have more access than those who have insurance, just due to the providers and systems that happen to be there. There are also some interesting programs. So another one in New Haven that is funded by the city. They fund psychologists actually to go into schools. So this is kind of a more preventive mechanism where the therapists are usually drama therapists and go into the schools from kindergarten and from a very young age start talking to children about these adverse childhood events and potential exposure to trauma and normalize those conversations and build those relationships over time. So if or when something should happen to a child, they have someone safe to talk to and can get help right away. And they can also provide services for that family, because usually if the child is in trouble, it means the family is actually in trouble. So there are, I think, some innovative programs coming out, but again, these are usually kind of few and far between. This program happens to be funded by the city. There are others that are just grant funded, and so when the grant expires, then what happens? But again, this is another place where we can start thinking about engaging healthcare but also models for payment. So there are newer models of payment coming out, thinking about the community as a whole. Potentially, how do we give money to a community to actually care for all of its residents? So programs like that might be able to provide some of that funding for the necessary psychologic therapeutic services that are needed.
We have time for one last question. We have a gentleman at the mic.
I have a comment more than a question. So I work at Connections, and we're the healthcare provider inside of the Delaware Department of Correction. And much to your point, one of the things that we've done, we've started with behavioral health. We haven't quite gotten to medical yet, is that we have an inside-outside program. We have psychologists who work on the inside who become the person's caregiver on the outside for behavioral health treatment. So the person has a fluid, seamless transition for mental health treatment from inside to outside. They don't have the same psychiatry provider, but they have the same therapist. We've done that with about 15 people. We'd like to expand it. You know, the funding inside is actually better than the funding outside for this service. Thank you, Delaware Department of Correction. But the Delaware Department of Correction actually contracts with us to provide about 100 different mental health clinicians inside of the system. We also have about 100 substance abuse specialists inside the system. So with the behavioral health contract, we serve about 200 people, most of whom are connected to one of our, upon their discharge or release, we have 10 integrated health centers throughout the state of Delaware. We start in northern Wilmington and we go to southern Sussex County, and we offer people an ability to come to one of our clinics upon release. Only about 40% of those with a behavioral health condition take that, but that's better than where we were 5 years ago when there was no connection between what was happening inside the Delaware Department of Correction and what was happening outside. You know, we partnered with coaches, the community-oriented correctional healthcare systems, and we've tried to work with them to break down the walls between what's happening inside and what's happening outside, because there was no ability to communicate between people. I think this is a great conference. We did one of these right before we started the healthcare contract in April of 2014. The rest of Delaware needs to get on board if this is going to be successful.
Excellent. And we'll thank you for the comment. I'm going to ask you to not leave early. Okay, so we can chat. Good. All right. I'm going to modify the agenda just slightly. We're going to have Dr. Emily Wang come up and give her presentation. And afterward, I don't need 15 minutes to close. I'm going to actually ask all four of our speakers to field questions for a few minutes afterward, because I understand there were more questions for both Dr. Carr and Dr. Rettman.